Hi, good evening, and thank you for attending our Ahead of Cancer lecture series this evening, sponsored by the Allegheny Health Network Cancer Institute. My name is Margie Leslie, and I'm a director for the Cancer Institute. There are a few housekeeping items that we want to review before we start. During the presentation, all participants can type questions into the chat or question and answer portion of the Zoom. We will be addressing those questions at the end of the lecture if time allows. Participants are not able to speak during the conference, but again, we encourage feedback via the chat option. Tonight, we are excited to welcome Dr. Patrick Wagner, Dr. Casey Allen, and Dr. Alexander Yu, who will be speaking tonight about high-tech cancer surgery, using surgery to deliver cancer treatment. Dr. Patrick Wagner specializes in the surgical treatment of digestive and complex abdominal tumors, including esophageal, gastric, pancreatic, liver, colorectal, and appendix cancers. He cares for patients with metastatic cancer, including liver and peritoneal metastases, as well as patients with rare tumors such as sarcoma and neuroendocrine tumors. Dr. Wagner serves as the Director of Complex General Surgical Oncology at Allegheny Health Network Cancer Institute. He received his medical degree from Harvard Medical School in Boston, Massachusetts, and completed surgical and pathologic residencies at New York Presbyterian Weill Cornell Medical Center in New York, New York. He completed a fellowship in surgical oncology at the University of Pittsburgh Medical Center. Dr. Wagner is certified by both the American Board of Surgery and by the Board of Pathology, and is a fellow of the American College of Surgeons and member of the Surgical Society of Surgical Oncology. He prioritizes patient-centered, individualized care planning in his clinical practice and emphasizes minimally invasive approaches, including robotic surgery whenever possible. Dr. Wagner strives to make innovative treatment options available to patients with complex cancers through translational research and clinical trials. His presentation will be followed by Dr. Casey Jackson Allen, who specializes in advanced surgery for complex gastrointestinal, pancreatic, and liver tumors. He cares for patients with primary and metastatic intra-abdominal cancers, skin and soft tissue malignancies, as well as those with rare diseases, including sarcoma and neuroendocrine treatments. Dr. Allen completed his fellowship in surgical oncology at the prestigious MD Anderson Cancer Center in Houston, Texas. He completed his general surgery residency at the University of Miami Jackson Memorial Hospital in Miami, Florida. Prior to his surgical training, Dr. Allen received his degree from Washington University in St. Louis, Missouri, and attended medical school in his hometown at the University of Nevada in Las Vegas, Nevada. Dr. Allen is a passionate leader of patient-centered care, specializing in evidence-based treatment pathways and preoperative optimization of surgical patients. As the lead quality officer at the AHN Cancer Institute, he ensures high standards to optimize patient outcomes. His leadership drives transformative changes in cancer care delivery, integrating cutting-edge treatments for all patients. Dr. Allen is dual certified by the American Board of Surgery in both general surgery and complex general surgical oncology. He is a member of multiple national organizations, including the American College of Surgeons and the Society of Surgical Oncology. And next, following that presentation, Dr. Alexander Yu will present. He is currently the System Vice Chair of the Department of Neurosurgery for the Allegheny Health Network. Dr. Yu's research endeavors have included NIH-funded research with intracranial aneurysms, clinical research involving novel biologics in spinal fusion, clinical research in the treatment of brain tumors. He received his Bachelor of Science in Biology, Master of Science in Biomedical Engineering, and Master of Science in Information Systems from the University of Miami. His Doctor of Medicine was obtained from the St. Louis University School of Medicine. His post-medical training in neurosurgery was performed at Allegheny General Hospital. Dr. Yu is a member of the American Association of Neurological Surgeons, Congress of Neurosurgeons. He is a peer reviewer for neurosurgery, operative neurology, International Journal of Spine Surgery, and Clinical Neurology and Neurosurgery. It's my pleasure to welcome Drs. Wagner, Allen, and Yu to present to you this evening. I'll hand it over to Dr. Wagner.
Thank you, Margie. Can you hear me? Just let me know.
Yes, we can hear you.
Okay.
Yes.
And I will begin to share my screen then. And then just let me know that this is coming up okay.
I see the view of the sidebar as well, but yes, I see your slides.
And how about now?
Perfect. Yes.
Okay, good. All right, thank you. So thanks for the introduction. I'm going to talk about a little bit different kind of technology tonight. I suspect Dr. Allen and Dr. Yu may talk about things that are conventionally high tech. But for my presentation, I'm going to talk about um, molecular technologies and other things that are maybe a little bit further outside the box, as opposed to robotic surgery or gadgets and gizmos that we use in the OR. As Margie said, I take care of patients with metastatic abdominal cancers, and I often take care of patients with this type of spread of their cancer, which is this is a picture of an incision in the abdominal cavity, and you can see the organs on the left side, and they're coated with a layer of nodules, which are tumor implants or metastatic tumors that are in what we call the peritoneal cavity. So I'm going to, excuse me, talk about three different ways that we've leveraged knowledge of how these tumors are structured on the microscope to try to bring new solutions to patients in the operating room. So I'm going to gloss over a lot of the science-y part of this, but I just want to show you some pictures, mainly the pictures, so you understand that the abdominal organs are in a cavity that is usually just got a very thin film of fluid. And when cancers spread, which is what's happening here in the middle of the middle graphic, they can begin to grow, and then eventually a lot of fluid can build up around the organs, and that's called ascites. And so we've embarked on some research studies to carefully identify molecules that we can use for treatment purposes in that fluid and in the tumors and in the lining. And this is a picture of a research protocol pathway that we developed to test blood, the fluid from the abdomen, and then you can see that the lower left panel, there's a set of pincers or biopsy forceps that we use to take tissue. And we're really looking to find targets. And my interest is in immunotherapy, and I think most of the new energy, or much of the new energy in cancer over the past decade, has been in immunotherapy. And so we're really trying to find targets that we can work with to be inventive in terms of new technology in ways that weren't possible before. And here's just an alphabet soup of different chemicals from the immune system that we found in that fluid. And that there's a tiny amount of that fluid in normal patients, which is what we found in the blue bars. The chemicals are listed at the bottom. You don't need to know the names of the chemicals, just to know that there's a bunch of different chemicals that we tested, and we found a few, especially right in the middle of the screen, that were very elevated in their levels in the orange bars, which are the patients with cancer that has spread to that cavity, versus the blue bars, which is normal fluid. And the one in the very middle is called IL-6. That's that tall orange bar. And we found almost none of that chemical in the blue bars, which are the normal patients, and huge amounts of that chemical, or it's actually more like a hormone of the immune system in patients with cancer. And so we designed a clinical trial to take advantage of that. And again, these are pictures really just to represent themes or ideas, but there are ways to try to block that chemical from binding to the immune cells and other cells. And when that hormone or that chemical does bind to cells, it generates a whole bunch of downstream processes that are bad for patients, for lack of a more scientific explanation. And we want to try to block that pathway. And there were drugs available on the market that are designed to block this particular chemical because it's an inflammatory chemical. And one of the drugs, this one called tocilizumab at the top of the list, is a very potent anti-inflammatory that's used for arthritis, rheumatoid arthritis, and was also used in severe cases of COVID to try to tamp down the immune response, which was creating very bad consequences for patients. So here's example of a high-tech concept where we study the fluid from the abdominal cavity, find a molecular factor or a molecule or a hormone that we think is very important in this fluid buildup and cancer progression, and design a high-tech way to get that chemical into the space around the organs. And so this is a clinical trial that we wrote and are running here at Allegheny Health Network to try to infuse that blocker that I mentioned, the drug that's FDA approved already, but to get it into patients using catheters that are specially designed to administer drugs into the body cavities to try to make a difference in patients that have either buildup of the fluid around their intestines or around their lungs in some cases. So I'm going to pivot now, and I was going to tell you just sort of three short vignettes, and that was the first one. The second clinical trial that we're utilizing is actually a very old concept, but it has been adapted to this situation using newer technology, and that's where the high tech comes in. So as I had mentioned before, these tumor nodules can land. They sort of start in any organ. They can start in the ovaries or the stomach, the appendix, the intestines, colon, and a cancer like that can grow through and perforate and start to land on other organs and grow. And we took a concept that is actually almost ancient in its recognition, which is that if you take a bacterial chemical or components of bacteria and inject them into tumors, it can cause the immune system to recognize the tumors very acutely. Whereas before, if the tumors are growing, it means the immune system isn't recognizing. So we developed a concept to take a purified component of E. coli, which is a bacteria that's just about everywhere, and to just purify the cell membrane or cell wall component or a structural component of the bacteria. And there's no living bacteria in this, but to inject this chemical into tumors during a laparoscopy, which is when we just sort of do an exploratory surgery with a camera to look around the internal organs. And then in many of these patients, we're doing that as a preliminary procedure. And then we're later going back a few weeks later, in this case, to go take out those tumors. So we had an opportunity to both inject the tumors with a medication, or not really a medication, but a chemical from bacteria, and then go get them, harvest those tumors a couple weeks later at surgery. And here's a picture of us injecting. If you look on the picture on the left, and hopefully all of you are, I should have warned you that there's going to be some pictures here over the next few slides that if you're sensitive, you may want to turn away. But otherwise, this is a picture taken during surgery, and you can see a bit of intestines, and here's the liver in the background. And this blob, this whitish tan blob right here in the front foreground, is a tumor. And this metal thing that you see here is a syringe that we are injecting from the outside of the patient's body, directly that cell chemical from bacteria into the tumor. And then on the right-hand side, you can see where we had taken some biopsies and injected tumors in a similar situation in a different patient. So that's what it looked like after we did the injections and the harvest. And so we have treated 12 patients at Allegheny Health Network with this bacterial cell wall chemical called LPS. And that was safely done in all the patients. They all had no side effects from the injection itself. They all had surgery 14 days later, and we were able to harvest their tumors. And we were able to measure changes, significant changes in the immune system reaction within the tumors by looking under the microscope and measuring different kinds of immune system cells to see if our technologic idea to inject the tumors had worked, and it appears to have worked. So we have a lot more work to do. This trial was just recently completed, and we have all the tumor samples in the lab to get down into the details with. But it's an interesting example of what we call translational research, which is what I have a graphic. I borrowed a graphic from a publication on the internet, but nevertheless, patients are the inspiration for all of these things, and we do work to try to understand in the lab what's happening in patients in the setting of disease, and then to design an experiment and test it in the lab and take it back to the patients, and then test the result of it in real time and then start the process sort of as a cycle all over again with taking the results, going back to the drawing board and trying to use technology to turn the tide in the battle against this type of cancer, which really has no cure at the current time. Lastly, and this probably will resonate a little more in terms of technology, there's a lot of words on these slides, just sort of tune them out. I'm going to tell you what you need to know. But we ran a clinical trial out of Allegheny Health Network a few years back. I think it was published last year in the journal, looking at a chemical with a very long name called pegcetacyanine, and it is a fluorescent marker that is preferentially taken up in cancer cells, and under a black light or under a certain wavelength of light, it fluoresces. It turns yellowish greenish. So the idea was that sometimes when we are doing a surgery to clean out all of these tumors from the abdomen around the intestines, it can be very hard to see them, and the number that you leave behind is very important. The more you leave behind, the worse the success of the surgery. So we really want to get every speck of tumor if we can. And this chemical was designed to try to help, almost like a light bulb, show us, where the trouble was and show us where the tumors were during surgery. And so I'm just going to skip ahead to the interesting part here, which was that this drug was given to patients the day before surgery, or sometimes a couple days before. And that gave it time to kind of go out into the body and hopefully be taken up by the tumors. And the way it was taken up by tumors is based on the metabolism of tumors. They have an acid pH in them, which causes this chemical to flip into a fluorescent state. And you can see pretty clearly in the middle figures here, this is just a portion of fatty tissue that you're seeing through the square of the operating room blue towels. And the ruler is just telling you how big this is, but that orange spot right in the middle is a tumor. And it's plain as day in this case that, where the tumor starts and where it ends and the normal tissue starts. And then on the second side, the right half of that picture, this is a surgeon's hands, and the surgeon's holding a piece of intestine and this tumor nodule sitting right on it. So it makes it very clear for us to see. And then all of the tumors that we removed during this clinical trial, we took to the lab and looked under the microscope to make sure that we knew whether there was cancer there or not. And the point of the study was to find out how accurate this was, this technique, and how often we were able to find extra tumors, so to speak. And there's just quickly to go through there is a bit of technology here. There's a special device that you see an example of in the middle, the cart there with a screen, and the camera is on the end of that arm. And the camera was used to shine a light and take pictures around the abdomen to try to help us locate any tumors that we might have missed. So here's a couple of examples of tumors that we didn't see under the naked eye, but they did jump out at us when we were looking at the images from the under the camera under the special light, and you can see how helpful that might be. And I'm going to play a very short video here, just showing you that. Let's see if I can speed it up a little bit. So here's an area where we were suspicious that there might be extra tumors that we weren't seeing very well. And you can see in here those orange dots. I think that's the surgeon's thumb is running over them to try to confirm whether those were actually tumors, and a little bit of blood. So if it bothers you, look away for a sec. That's a cautery device that we use there in fast motion to just stop any bleeding and destroy any tumor cells. The one problem I will say is that you can see that the intestines themselves light up pretty orange as well. And probably the hardest part about this particular agent was understanding here, for instance, there's a very bright orange lymph node. And so some of the normal tissues also light up because they have acid pH in them normally. And so we did have to sort of go through the results pretty clearly to determine false positive rates, which were not as low as you'd like. And so, in other words, although this was a great idea, and I hope it turns into something more valuable down the road, at the current time, there's probably too many false positives for us to really rely on it, because sometimes if it lights up and you take out a piece of normal tissue, you can imagine how that would become potentially a risk to patients over time. So just to conclude here, I'm talking mostly about high tech in terms of clinical trials and bringing the technology into the patients' bodies, literally, in terms of patients with metastatic digestive cancers. And uh, just again to uh, emphasize that this is all happening at Allegheny Health Network. Some of these trials are still open, some of them are complete now. We have others on the way. And our goal here is to transform cancer surgery into a future where taking the tumor out physically, which is what surgeons historically do, really is only one part of a bigger process to restore cancer patients to health. And to try to find any way that we can to be inventive with new technologies to harness the immune system. That's my focus, and others, have other ideas. But that's what I wanted to tell you about, and I'll probably should stop there so there's time for everyone else to speak.
Thank you, Dr. Wagner. I believe we'll be handing it over to Dr. Allen.
Hey everyone, good evening. Just let me know if you can't hear me. I'll share my screen. And so if you might have remembered, thank you, Marjorie, for the introduction. I am also a surgical oncologist. I treat a lot of the same diseases that Dr. Wagner treats. He's obviously very engaged in the molecular mechanisms of cancers and ways to use high-tech surgery and high-tech technologies in general to treat that aspect of cancer care. My interests are more in health systems and delivering quality-based cancer care. So I'll talk a little bit about that and then some other high-tech aspects of cancer surgery delivery. This is a big eagle's eye view of how we like to deliver surgical care. This is called enhanced recovery. The red line is essentially the way that patients would recover from surgery, where they would have the surgical procedure and then they would obviously have an impairment in their functional capacity, obviously due to the major surgical intervention. And then their recovery would be long and prolonged. And there's been major advancements in the way we provide cancer surgical treatment to augment their functional capacity in order to improve their recovery and get them home healthier, faster. Things like multimodal pain relief, exercise, early feeding, really just evidence-based practice over the last 40 or so years. So one thing we do, I'm not going to get into the details of this, is that we have clinical pathways for all of our surgical patients where every single day, from the preoperative setting, the operative day, the postoperative setting, and every single day thereafter, we have evidence-based pathways for the care of those patients. And these are based on existing literature that shows improvements in their functional recovery and getting them out of the hospital faster and stronger. And these are based on not only existing studies, but recommendations from organizations such as the Enhanced Recovery After Surgery Society and the American Society for Enhanced Recovery and Perioperative Medicine. One huge aspect of enhanced recovery in getting patients through a surgery and home faster, healthier, is the advent of minimally invasive surgery. Many of you have probably heard of laparoscopic surgery, and now we use what are called robots, and I'll talk a little bit about that. Robotic surgery to perform complex surgery. So here's a diagram, not to get in too much detail, but this is a diagram of one of the more complex surgeries we perform, which is called the Whipple operation. This is a diagram where someone has a tumor encasing the pancreas, and it's heavily involved in some of the central blood vessels in the body. To perform this surgery, we would have to remove that portion of the pancreas, several portions of the intestines, the liver, dissecting it from major blood vessels, and then ultimately putting things back together so the patient can eat, drink, and live a normal life. Now, traditionally, and still in certain circumstances today, this is done through an open midline operation. So large incision, basically just below your rib cage, all the way down to your lower belly. Large incision with drains. Patients are in the hospital for many days, if not potentially weeks, recovering from a large operation. Now there's been the advent of robotic surgery. So using advanced surgical equipment to perform these procedures. So here's just a little shot of what we use in the OR these days. There's a large computer platform that integrates the console where the surgeon sits and the instruments that are utilized for the patient. So basically, we utilize the robot to place small incisions to enter the surgical tools. Here's a diagram of placing these small tools within the abdominal cavity. And then the surgeon will sit at a console and control these robotic arms and perform the surgery within the belly. So traditionally, PD is just an acronym for the Whipple operation I was referring. Traditionally, large incision, putting in retractors, doing the surgery, basically what we consider the old-fashioned way, to now putting the instruments within the abdominal cavity, better visualization, more meticulous dissections, and as you can see, much smaller incisions. And it's not just about cosmesis. It's about getting patients better faster. So patients who undergo minimally invasive surgery have less pain. They're up and moving faster. They have faster return of bowel function. They get home quicker, and their stress induced from surgery is much less. In addition to technologies itself to enhance the way we get patients better during and after surgery, is the concept of what we call prehabilitation. So you've probably all heard of rehabilitation, where you get better after surgery, like cardiac rehabilitation and things of that sort. But the concept of prehabilitation is getting patients better before surgery, getting healthier and stronger before surgery, so that their functional recovery is then augmented after the surgery. So for cancer care in particular, we give a lot of treatments before surgery. So this is a little diagram where we show OR means surgery right here. And this is what we call the preoperative treatment phase, where we give sometimes radiation, sometimes chemotherapy. And we're doing this more and more for other types of diseases. So this is good. These treatments are good for treating cancer, but it also gives us significant time to optimize patients prior to surgery. So we've developed what's called the pillars, what we call the pillars of prehab. So it's not just about exercise and nutrition. It's about exercise, nutrition, medical optimization, supportive care, education. So much goes into what to expect and to be prepared for a large, complex abdominal cancer surgery. So we've worked to actually streamline these resources to all of our cancer patients. As we've been doing this, we've actually identified opportunities to improve each of these pillars. For one, supportive care, navigation, education. Patients undergoing major abdominal operations often experience a lot of anxiety. They don't know what to expect. This can significantly impair their experience and also impair their recovery. So we've actually developed a perioperative supportive care program where all patients undergoing major complex abdominal cancer surgery are provided support by a behavioral health specialist. He also provides education on what to expect, anxiety relief exercises, and then when they do undergo their operation, he's there in the hospital with them and helps them through their experience. And then after they get discharged, he follows with them as well. Another thing we do at AHN is improving the way we engage patients for exercise. So we obviously make formal recommendations for exercise, but we always look to engage them more. So we do have an exercise facility with a Dr. Colin Champ, But a lot of patients can't actually physically go to that facility. So we've developed a way to engage patients in their home so they don't have to travel and they can perform exercises prescribed by a therapist, nutrition prescribed by a nutritionist, interact with them on an app with their phone, and then get real-time feedback and therapy recommendations as well. Additionally, nutrition. Now, there's extensive research that shows that preoperative nutrition shakes for the week leading up to surgery by carbohydrate loading and immune modulation improves outcomes by decreasing infectious complications, therefore getting patients out of the hospital faster, improving their outcome, and decreasing costs of care to the patient and the provider system as well. And we're working to get this to every single patient who we have surgery within our division. Moving a little bit aside, some of you might have heard of what's called value-based care, which is delivering high-quality care at low cost. So we really strive to deliver value-based care for our surgical patients. Quality is defined by multiple metrics when we talk about cancer care. So when we talk about quality, we talk about survival, complications, their functional recovery, their experience, their quality of life, costs to the institution, the patient, their family. So some of the research that we do with our group is to understand how to best define value and how to best deliver value. So we've actually surveyed a large population of cancer survivors, cancer caregivers, cancer providers, and researchers to understand how they prioritize certain aspects of cancer care delivery. So I don't want to make this too confusing of a diagram, but essentially these are the metrics, the value-based metrics such as quality of life, survival, access, costs. And it shows that these metrics are extremely important to patients when they're receiving their cancer therapy. So the most important thing that patients care about is quality of life and their survival, amongst other measures. We've used this information to try to expand the way we consider value to the patient. So this is what's called a survival curve. You guys don't need to know really what that means, but this is what oncologists look at when we compare two different treatments. And it basically projects the longevity of the entire population of cancer patients that are studied between two treatments. And the bottom line is there's a marginal difference between treatment A and treatment B here, just a minute difference. And a lot of times we base our treatments on very small survival advantages between two treatments. But really our goal, as I was alluding to some of our earlier studies, is to expand that concept. Look at treatments not on a single dimensional aspect, but on a multidimensional aspect. So look at the implications, their survival, their costs of care, their quality of life, and the time that it takes to receive those different treatments. And then the patient themselves or other stakeholders can make a more informed decision on what treatment is best for them. So treatment A here, although a slight difference in survival, much better quality of life, less costs, less toxicities. So depending on the patient's priorities in their care, they can make a better informed decision for their treatment. Within that, delivering value-based care, we find that it's extremely important to engage surgeons as leaders. We find that when surgeons are in leadership roles within hospitals, the hospitals perform better, have higher quality scores, reduce complications, better efficiencies. And these leaderships can be learned. So we're looking to train our next generation of surgeon leaders to not only be good surgeons and good doctors, but good leaders delivering value-based care. Just a little preview. These are our current research fellows within our division. I talked a little bit about enhanced recovery after surgery. They are working to put together, they actually have approved a protocol. They've put together an IRB-approved protocol for a randomized trial looking at different ways to provide local anesthetic to patients undergoing minimally invasive robotic cancer surgery. So a 3-arm randomized trial in order to help patients get through surgery with less pain. they're also looking to see if this remote platform to engage patients for exercise is better, or at least similar to that of in-person coaching exercise program. And finally, they're helping to expand this framework for measuring and communicating value by surveying a large cohort of cancer patients, caregivers, and providers to see if this tool helps them make treatment decisions for themselves. So a little bit of high-tech talk, but I really wanted to give a bigger picture on how we deliver cutting-edge surgical cancer care within our division at AHN. So thank you for your time. This is my email if you guys want to reach out. And if you guys want to take a little snapshot with your phone I have a URL there, or that'll follow you to a link to get more information on some of the work that we do. Thank you for your time.
Thank you, Dr. Allen. We'll move forward with Dr. Yu's presentation. Welcome, Dr. Yu.
Want to make sure you guys can see my screen okay.
Yes, sir.
Hi, well, thanks for having me. I think what's interesting about neurosurgery is one of the reasons why I went into it is actually the technology. It's one of the younger specialties of general surgery. And what's interesting about from our standpoint is that we deal with the neurological and also the oncological side of cancer treatment. Here's and I'll tell you there will be some pictures, obviously, and if there's any difficulties, obviously, please look away. But this is an example of how we look at the brain, and this is obviously a cadaveric specimen. This is not something that we normally do to patients on a daily basis. But if you look at it, it's a very homogeneous structure, but somehow at one point we're able to figure out what parts of the brain do what. And if you look at it, there's a lot of neurons there. It's a lot of surface area. That's what you hear about, is why there's so many folds inside the brain tissue, is really because there's a lot of neurons there. So what you're seeing here on the screen here is that the gyri is what we're talking about, is basically the clumping. Those are that's kind of the computer part, of the brain. And deep within that are gaps that you're seeing, and within those gaps are where those wires run. So we think of the outside surface as the computer part, and deep into that are the wires, and that's how you get all that surface area. And what's interesting over time is this is actually a drawing from almost 100 years ago. Some of our founders of our specialty, Harvey Cushing and also Wilder Penfield, initially realized that there's certain parts of the brain did things, meaning a certain tumor in this location would cause certain problems. And over time, they discovered that over about 95% of all people, that this area of the brain causes certain things, meaning motor function and whatnot. And as you go throughout more and more, at one point, if we're trying to figure out these things, we can actually electrically simulate those parts of the brain and either get a response or shut down a response. And this is one of the earlier drawings, and this is about 100 years ago. And I think what's always interesting is that 100 years ago, people were doing these types of surgeries, and that we're able to do them. And you can see here on the screen, it says on the front, it says eye. And then here, this is the left side of the brain. This is where the speech areas are. And these are the locations generally that we saw that this controlled certain functions of the brain. And eventually over time, we developed into this, what we call this homunculus. And it's real simple, is that green dotted area that you're seeing here is basically the area that's what we call the primary motor cortex. And what that functions as is basically is kind of we think of as a somewhat of a no-go zone. There's other areas that you can see in the front here. There's what we call the supplementary motor cortex. And that primary motor cortex is the main function, the main areas of the brain that provides that function for instance, moving your arm and moving your leg, and other areas of the brain help with that. but we've identified that area. And what's interesting about it is that the sensory function that you're seeing, that dotted green area, is primarily what controls the hand. And if you look next to it, the dotted blue area is actually what controls the sensation. So, for instance, the motor function for the hand is actually right next to the sensory function, for the hand. So I think it's pretty interesting how organized over time that the brain has looked. And I think some of you guys have seen in some early psychology textbooks and neuropsychology textbooks, that this is kind of the way that most people's brains are laid out. And what's interesting is this, these are in proportion to the amount of neurons that are attributed to that function. So if you look at the hand is actually the thumb, fingers, hands are actually a pretty big, component of function, because there's more neurons that are required to perform minute functions like, for instance, just touching your index finger to your thumb. Those are a little bit more coordinated than, for instance, like your knee. Your knee kind of just moves back and forth. If you look at the diagram here, you can see the face actually takes up quite a bit of that brain structure, because we have facial function. We have different intricate movements of our face that makes us human, that gives us the semblance of expression. So what's interesting, over time, you can actually develop this and do what we call neuromonitoring, which is kind of the kind of the mainstay of the standard technologies that we use. And one of them is SCCPs, and it's very simple. Is I can somehow monitor, because we have studied over 100 years ago, we've studied all of those functions that supply sensation, that in fact a patient asleep, I can actually detect where that location of that brain tissue is. And basically, in a nutshell, what it comes down to is, if I can, for instance, have someone move, we stimulate their hand to move, those signals actually get back to the brain, and we can actually determine the areas that are important for motor structure, motor function. So, for instance, that example that I mentioned before, where the motor function is next to the sensory function, that if I can find the sensory function, then I actually can find out where that motor function is, and I can determine whether or not it's worth it to remove tumors in the location, or I can determine whether or not that tumor has pushed all those structures away from, either in a moving them in front of the brain or in the back of the brain. So I think that does help us determining that location. So when we remove tumors in that location, we can find a way to basically make it safer. The other cool thing, what I do find is interesting, is the study of, for instance, hearing. The idea that I can figure out with a reasonable degree of certainty whether or not I'm affecting someone's hearing function while they're asleep, I think is pretty neat. In fact, basically the setup is there's a device that basically puts little clicks in the ear, and I can actually connect to what we call these nerve bundles. And what you're seeing on the screen here is the 1, 2, 3, 4, 5 is actually each area processing that the hearing is processed through. So, for instance, the first one is where, for instance, that's where the first processing is. Then each of those Roman numerals is where those functions occur. And what's interesting about it is I can actually monitor to see how healthy that hearing function is while a patient's asleep. I think this is pretty interesting, and you can see in the lower in the C in the diagram C, you can see here is where you can see the red dots. As you can see, the red dots kind of veer towards the right side. That's basically telling us that we're putting too much pressure on that nerve. And if you can see here, the microscope comes in to look at the nerve, then a retractor is placed, and you notice that the retractor is in a location that starts to affect the hearing, and then you can see the retractors are removed and the hearing recovers. So I think this is probably one of the coolest things is I can test those, that test the patient's ability to hear, test their ability to function with a reasonable degree of certainty that I can say, hey, this patient's going to wake up okay. And yes, the original surgery to kind of figure it out is the awake craniotomy. I think this is what's pretty interesting is if you see ads on TV and find out that this is actually a technology that's been around for quite a long time. This is actually not one of our patients. This is actually a Google search for an awake craniotomy. So, and I think that's what's interesting is I have the ability to, for instance, in a awake craniotomy, I can test someone's ability to understand and make speech by basically placing an electrode over that area while they're making speech and shutting that down. And I can actuality map out their ability to make speech. Sometimes there's been documentation that you can map out the ability where someone's different languages are, and the ability to make mathematical calculations and whatnot. So I think pretty cool stuff. But the funniest thing is this was done over 100 years ago, but we still use these tools to kind of maintain um, the health of our patient. Some of the other technology we use are brain ports. This is the example that, as I mentioned before, that those gyri, those thickened parts of the brain, I can actually go in between those crevices to access some of the deeper tumors. And this is they go in various lengths, they go in various widths, but the idea behind it is if I can push a little bit of pressure on those nerves that they can tolerate, I can still access a deep-seated tumor as opposed to moving towards a tumor that makes it that potentially is near structures that are vital. And here you can see an example of some of those structure. This is actually on the upper right hand is actually the ventricle, which is actually literally in the middle of the brain. It's a fluid-filled space. And obviously going in by removing all that brain as opposed to using a small port, you afford the patient, unfortunately, more collateral damage by doing it that way. So we have these technologies at AHN, and this is one of those examples. And I'll kind of go through some of the things that we can do is we can actually map out by watching. It's really, I think the coolest thing is I can watch the way water moves throughout the brain because it's a area that has a lot of water, has a lot of insulation, and I can figure out kind of where these wires are going internally in the brain. And you can see there's on this MRI, there's a port here, but then I can actually go in between those fibers or those those neurons that are inside the brain, and I can avoid those areas to attack a deep-seated lesion. Here's an example of another lesion, and you can see this is what we call diffusion tensor imaging. And like I said, it works with the movement of water throughout, and you can actually see I can attack a very deep-seated structure. That's that bright white structure, literally in the middle of the brain, with the least amount of collateral damage. So and we think about, let's say, for instance, this is an area that you can see here, that little white spot. If I wanted to attack that white spot, I can use a small port, but instead of using a small port and going through all of these structures that the cool kind of colored lines throughout the brain tissue, I want a more minimally invasive system. And if you think about it, in terms of I can make calculations, and that's what was historically done, but I can make calculations, but I can certainly be off. If I'm off 10 degrees, I can be off a centimeter off of that structure, which is actually the width of that entire structure. So one of the options that we utilize is neuronavigation, and this is an example from the internet, of a neuronavigation um, um, registration process, and where it comes down to is very simple: the globe, the Earth. At one point, and we still do, we were trying to find oil, and we can triangulate finding oil, and it's the same thing. If you look at the globe, it's the same shape as a head, and if I'm trying to find a deep-seated structure, I'm able to do that with the neuronavigation. So if I can find and access deep structure, then what can I do with that afterwards? Then I can actually heat that structure up. And if I can heat that structure up and the other components, let's say, how high do I heat that structure up? And this is where laser therapy comes into play. And this is one of the examples of one of the laser probes that we utilize. And this is an example from a journal article of a probe. And if you imagine that little probe is placed through a small opening in the skull. And by doing that, I can actually avoid all those important brain structures, and I can place that probe through. And if I can figure out what temperature that is, which I can do with MRI, I can heat safely heat some of that brain tissue up to basically kill that cancer. You can also obviously use more than one probe. In fact, this is one example of if you look, this is a pretty large brain tumor that if you look on that bright white stuff on the screen, that's the tumor. And then if you look kind of before and after, you see that all that bright white is kind of taken away and everything. So so how does this work? It's basically a software evaluation of of brain tissue. This is one example. I can tell how much tissue is being ablated over either temperature and time, and it's a well-defined zone. And I think that's where accuracy comes in, and I can figure out temperature. So for instance, in this picture here, I can see basically it's real simple. It's the more red, the hotter it is. The blue, it's less hot. And over time, with those calculations, I can actually calculate and say, how much have I, killed that tumor? It does vary. So for instance, I tell people that there's a analogy of stir fry. If I heat it up very quickly for a short amount of time, it kills the tumor. Sometimes I can do what we call kind of more barbecue or it's kind of slow cooking, low temperatures for a long time. So all those equations add up, and I can figure out and basically kill a tumor with the least amount of collateral damage. Some of the other stuff I'll move very quickly. I know we're running out of time, but yes, if I look at a brain tumor itself on the left hand, you can see craziest thing is the brain tumor sometimes look like brain. And I think that's where the difficulty is. And you look on the right side, this is one of the drugs that we can utilize to light up those tumors under a black light. And I can actually figure out, hey, this is tumor, this is not tumor. When you look on that left side, it's a little bit hard to tell. Some of the other things that we do utilize and are more MRI basis, perfusion weighted imaging. Basically, I can tell if a tumor is basically having more activity, less activity. The other testing that we utilize at AHN is functional MRI, and it's real simple. It's the metabolism that we can detect through the MRI that I can have a patient talk. I can have a patient move their arms and legs, and I can light up specific areas of the brain. So it's another addition to what we utilize in the OR electrically. This is more of a visual. I can say, hey, functionally, this is where those major neurons for speech are. The other things that we also have is spectroscopy. I can actually take a section of that tumor through MRI, and I can figure out the chemical components and give the patient some sort of idea of what kind of tumor we're dealing with. So I think, like I said, I went to neurosurgery because of the wonderful technology we use, and we utilize quite a bit. And these are some examples of some of the things that we're doing here at AHN. Thank you. I think you're muted.
Oh, thank you, Dr. Yu. Thank you for letting me know. I'd like to thank each of the physicians for their very informative presentation. We do have a few minutes left if anyone wishes to drop any questions into the Q&A. I do see that there's one person who'd raised their hand, but we're not going to be calling on folks to speak. But if you would like to type in a question, please feel free to do so. I'll pause for a minute or so to see if any questions come into the chat before we close. Okay, I'm not seeing any questions coming into the chat. So if there are no questions, we'd like to thank you all for attending our Ahead of Cancer lecture this evening. Please continue to join us at our monthly Ahead of Cancer lecture series as we focus on cancer screening, early detection, treatment, as well as survivorship. As a reminder, tonight's lecture was recorded. If you are interested in rewatching this lecture, check back on our AHN YouTube channel, www.youtube.com/Allegheny Health Network, for the full recording in about 1 week. This video, as well as other past lectures, will be posted under the Ahead of Cancer playlist. If you would like to schedule an appointment or have any questions regarding a potential cancer concern, please call the Hope line at 412-578-4673 for further information. Thank you for the great presentation to the physicians, and thank you for all those who lectured this evening and who attended the lecture this evening. And we wish you a great evening. Let me just check the chat. No additional questions. So thank you and have a wonderful day.